This is a common problem which we see among the type 2 diabetes and increased level of uric acid. And yes, it is a challenging to manage this both together in one client or one patient. And that is what we want to discuss here with case-based discussion, how a dietitian or a nutritionist, how well you can tackle or manage both hyperglycemia and hyperuricemia at the same time. So in order to learn that, we really have to learn the physiology, we really have to learn to the metabolism, the different pathways, the byproduct of uric acid, and the correlate it with the consumption or food intake of the client. And that is how we'll have to carefully note down the history, and then one by one, once we arrive at the nutrition diagnosis, and before we begin the nutrition intervention, we really have to think critically here and tackle this both symptoms together. And we have none other but Geeta Dharmatti, Dr. Geeta Dharmatti, an expert who has seen so many patients of this kind and managed them so beautifully. So we would like to begin today. Over to you, Geeta.
Thank you, ma'am. Definitely, we will be taking Salome map inputs wherever we wish to take. So it is just an overview of diabetes and uricemia. As you all know, BNA Life have started now talking about application-based dietetics. We want all of us to learn case-based application, and that's the beauty of these sessions, I think, where you and I, when we handle patients, we want to learn what exactly to look in for. And we can't have a great mentor than Salome ma'am to help us to see what best we can do to the patient, counseling techniques, screening, and applications. So let's take an interesting topic today, which Nazneen already has introduced. Hyperuricemia and diabetes. We are doing a diabetes series, and now we have taken uric acid as one of the diabetic metabolic complications which we want to see. So let's take an interesting case here. A menopausal woman, 51 years. She just is in menopause, 1 year out from menopause. Not a great BMI. It is 71 kgs for 165, 65. So overweight category of BMI, 25. She is known hypertensive. She's complaining of continuous muscle pain, body pain, backache. She is known diabetic. She has hyperuricemia now, and she had been through a COVID positive in 4 months. And lifestyle, definitely as a 51-year-old, we know that she's sedentary, not great exercising person. She has on and off gastric distress whenever there's change in food, environment, water intake, travel, sleep, etc. She is on medications for both diabetes and hypertension. For a routine checkup, because she has a lot of body pain, she has been to the medical management who have asked her to go for testing. And on going for the further evaluation, it was found that her blood levels were deficit in B12. Her blood pressure was almost normal. She was on drugs. D3 was okay. She could do better. 37.7. You could see the hyperuricemia, which is not very common in females, but we have seen 9.3 as a uric acid level here. Calcium was okay. HbA1c was 8%. Fasting was 120. PP was 240. She was known diabetic, but still her HbA1c, I think, was not in control. Fasting also on a higher side, and PP also 240. Overall, patient menopausal, post-COVID, trying to work good on energy levels. Not a great exercise person because body pain, lethargy, it may not be a major issue here. Her recall says typical Indian diet where she has a mixed diet. She does have non-veg 2 times a week. She has dairy 300 ml every day. Look at the vegetable intake, not a great vegetable eater. It was just for roti, she eats bhaji. But otherwise, a mindful discipline, not emotional eater, not overeating, not sweet eating. So there's not much eating. But yes, look at her diet. It is a biscuit and a chai, a breakfast of a grain-based food, Indian breakfast with a fruit, tea, 2 fulka sabji dal rice, tea with 2 biscuits, a fruit again in the evening, and a typical dal chapati. And she cut down her 1 chapati and little rice for dinner. She wanted to have a light dinner. So we should say she's a mindful eating person, which actually should have given her a good BMI, a good health, wellness prevention. But yes, she does have hyperuricemia and she has diabetes. She is on supplementation vitamin, calcium, and D3. So I think the case is very clear here. And now we go on to understand how we manage it. Ma'am, anything you would like to highlight here once I finish the case, that how you would start looking at this patient?
Yes, go ahead, Geeta, because as
Sure.
per the parameters and as we take the history, we will see how we tackle this case.
So friends, I think now you got an idea that though not a very, we know a metabolic syndrome is a difficult to manage, an indisciplined lifestyle and all, but this female postmenopausal is very good to manage. There's not much factors which may lead to such a hyperglycemia and hyperuricemia. So let's understand physiology, as Salome ma'am started by saying. We should know why a person gets into hyperuricemia. What are the pathways? What is contributing to a higher purine level in our body? Is there a problem with absorption or excretion? So let's try to understand where we are not able to balance the purine levels. The diet doesn't look bad. The weight doesn't look bad. There's only hyperglycemia. The HbA1c is on the higher side. There's a postmenopause and there is a risk. There is a background of COVID infection. So these are the areas we are looking for now to make us understand what do we handle. Should I give her a diet chart of saying no proteins at all, because you look at her diet, not very great protein eater. She does need calcium. She does need a good muscle mass. So what are we trying to work on here? So let's go back to some uric acid biology and some biochemistry and understand. So there are modifiable and non-modifiable risk factors. Non-modified, no choice with age, gender, sex, and ethnicity. We know that males have more probability than females. And modified, we know that, okay, obesity, blood pressure, lipids, ischemia, IHD, diabetes, CKD, dietary factors, alcohol, medications which alter the balance. So now, where we have a lot of factors which are modifiable. So let's pick up few and understand. Before we get into the basic of uric acid and dietary management and protein management, we'll understand what a purine molecule looks like. We all know a DNA structure, the backbone is purine and pyrimidine. So if you look at this purine molecule, purine has guanine and, two nucleotides, which is guanine and adenosine. And the third one, you look at it as SAM, that's a methyl donor. So the molecule looks very clear that with guanine and adenine as a nucleotide base, we all know that we need to understand this structure and see what are the changes which takes place. With R1, R2, and R3, there are a probable changes of oxidation, reduction. They get into ribose molecules. So they get into a kind of a methyl donor. So these are where this purine, apart from the background of being in a genetic DNA structure, these are where these purine molecules come into the picture. So how we look at purine metabolism? How does a purine form and how does it metabolize? So there are 3 grades, they say: de novo synthesis, catabolism, and salvation. We'll try to understand each in detail, and there are n number of pathways which leads to it. Before we go, I will like to take you to this slide so that we are more clear, and then we go each area of purine metabolism. Let's look at the factors. Look at the factors which lead to it. We have a patient who's diabetic. We have a patient who's postmenopausal. We have a patient who has had a COVID infection and hypertensive. Let's keep this in mind. And yes, BMI 25, maybe she has more fat than muscles that we've not checked, which we should do it as a part of understanding about her body composition. Now, if you look at this pathway, this is a very beautiful slide I found, that this tells me a typical hyperuricemia management, metabolism. One factor which contributes, let's start because she's diabetic, we'll look at the insulin factor. We were talking about increased amount of carbohydrates in the diet. And we all know that that talks about that your HMG pathway. So HMP pathway is when you have a higher amount of glucose, when you have a high carbohydrate diet when you are on a high carbohydrate diet and you are insulin resistant, you definitely have an increased amount of ATP synthesis or breakdown. So that insulin resistance gives you a glucose 6-phosphate, and this is something called as PPP, which we will go in detail. Then you have another factor which contributing apart from a high carbohydrate diet is alcohol. And we also know that alcohol also leads to the metabolism from glucose 6-phosphate. The third area which contributes to purine is fructose intake. And we know that fructose, high amount of fructose gets into glyceraldehyde 3-phosphate, goes to fructose 6-phosphate and leads to a pathway where you have a hyperuricemia incidence. Then you have a increased purine dietary intake. That's one of the area which we want to understand. Increased purine dietary intake, where we can actually work on as a low purine diet. Purine degradation, it also leads to the pathway where you have a hyperuricemia. So you now understand from this pathway that yes, it's a hyperglycemia, insulin resistance, it is alcohol intake, it is fructose intake, it is purine, dietary purine intake, which may actually lead to an increased amount of PPP, which is ribose 5-phosphate, which gives the inosine, and then hypoxanthine, xanthine, uric acid. We'll all take up respective slides for all of this, but to make you understand behind the scene, de novo pathway, catabolism pathway, and a salvage pathway. Ma'am, would you like to comment on this slide?
Go ahead, you are on the right track. That's
so now
to explain today.
Exactly. So all these are the factors behind hyperuricemia. So when you see a patient, if you just say that, okay, let me give a low protein diet, cut down proteins, doesn't make sense. Let's go and see the background. And now you realize for this case, is hyperglycemia contributing to her hyperuricemia? Because there's no alcohol intake. There are only 2 fruits in a day that will not give. So where she's not dyslipidemic either, because fructose intake also gives you TG accumulation. So now let us understand going ahead that each pathway will try to make it more detailed. I won't go through the detailed pathway. This is not a biochemistry class, but somewhere the background of understanding that if I have a high carbohydrate diet, a lot of glucose, glucolysis, gluconeogenesis, which definitely you all know leads to a hexose monophosphate pathway. So here you have an hexose monophosphate pathway where a glucose tries to convert it into a glycolysis cycle. This cycle is glycolysis, which is the primary cycle of energy metabolism, which we all of us have learned. And in that, if there's an excess glucose, we know that there is a risk of increased ribose 5-phosphate. This is called pentose 5-phosphate, PPP. So this pentose 5-phosphate increases. Why? Because there's increased substrate of glucose. So increased glucose, increased PPP, increased PPP, definitely you know that this is a precursor for your purine metabolism, which we have just seen here. When you know ribose 5-phosphate increases, you have a background of which gets converted into inosine, hypoxanthine, xanthine, uric acid. So I'm sure by now it is very clear on your mind that one of the contributing factor is an increased substrate of carbohydrates, glucose. The second thing which we would like to have a simple purine metabolism pathway. If you have a higher energy expenditure or intake, it can be ATP depletion. It can be too much of food, excess of food in the diet, obesity. So it can be anything which contributes to higher energy. If you have an athlete who actually burns a lot of energy. So if your energy consumption, if there is ischemia, if there's a lot of catabolism, there definitely is an increased cellular turnover. Cellular turnover can be a byproduct of food, can be a byproduct of internal mechanism. And from that, you definitely will have an increased purine in your blood. And you all know when the purine has to degrade itself into xanthine, hypoxanthine, xanthine, and uric acid. There's another possibility of deficiency of the xanthine reductase enzyme. If there is a reduction, there is a gene mutation here most of the times, or if the enzyme XOR is not available because it's higher generation of purine. Higher generation can be because of any reasons, friends. So if this is XOR increased if there is a less amount of this enzyme, then also you have a higher amount of hyperuricemia. So interesting it is that this uric acid in other primates or other than mammals actually gets converted into allantoin, and this allantoin is a potent antioxidant. So sometimes uricase, where vitamin C also helps in a better management of uric acid, which tries to reverse the pathway where the purine metabolism is slowed down. So again, I'll take you back to the initial, we can call it as a master slide, which talks us about all the reasons that this pathway where I have a increased purine, this purine intake, purine degradation, increased energy. Energy is all about ATP, friends. ATP, the A in A is adenosine. So which is nothing but the interconversion of adenine. So this adenosine gets converted into inosine. All these are mono, di, triphosphate, which are the interconversion of energy. And then that might lead to hyperuricemia, allantoin, allantonic acid, glycolic acid, and finally urea and out of your body. This is how it should be working as. Another imbalance can be, suppose I'm having a high amount of urine, which we just discussed. It can be exogenous from food. It can be endogenous from your nucleotides, from your energy management, from your HMP shunt, from your genetic reasons. It can be anything. Here, if I am able to not, also fructose here, if there's high purine in my blood, and it may be overproduction of purine, which actually has to be metabolized from uric acid to gut to 30%, and kidneys take up 70% of the load. So either it is overproduction or it is inadequate renal excretion, which is 70%. So there may be drugs which hamper the uric acid metabolism. So this again is somewhere we try to look at 10% overproduction, 90% inadequate renal excretion. So that's why you will find a lot of CKD patients also having hyperuricemia. That's another area which we try to manage. But the question is, do I cut down protein or do I start looking at how do I actually address the overproduction with the help of medical management? Last area, I think we've discussed all. Fructose is very clear from this pathway. Increased fructose intake, which is generally from high cornstarch fructose sugars, not from the fruits generally, friends, because you don't end up taking so much of fructose from the fruit. Fruit has sucrose and fructose with fiber. The quantitative approach towards fruit, I think, cannot go beyond 150 to 200 grams. If you have a lot of fructose, you also have GI distress. So this, I think, is only from HCFS, which we generally end up getting into a management of where fructose 6-phosphate, and there's an ATP which gets out. It gets into the metabolism of glyceraldehyde 3-phosphate into the glucose 6-phosphate metabolism and can come into the purine metabolism or can go into hypertriglyceridemia. So this is such a beautiful way of looking at it, that one purine metabolism is being looked at from so many angles, right? So the third thing which you need to understand is there's a role of folic acid in purine metabolism. Let's not get into too much of details of methylation and all that. Because we are looking at hyperuricemia and hyperglycemia. So look at the folic acid playing a very important role in purine synthesis. So if you look at this cycle, 5-10, there is a conversion of folic acid to folate. The folate gets converted into two stops, which is tetrahydrofolate and 5-10 methylene tetrahydrofolate. Can we have the audio muted? So now this 5-10 methylene tetrahydrofolate donates a methyl to purine. So if you do not have a folate mechanism in place, you may have a higher purine synthesis. What I mean to say that if you keep taking folate supplements without knowing whether you need folic acid or folate, too much of folate can also give you increased purine synthesis, which may give you a hyperuricemia. So the drugs which address uric acid metabolism, which you generally see in the prescription when patients take it, it actually works at the enzymatic level from hypoxanthine to xanthine, where you have xanthine oxidase, and you have febuxostate state, which works at xanthine to uric acid. So it actually blocks the enzyme which converts hypoxanthine, xanthine, and uric acid. Generally, you have, or you can be given uricases, which gets converted into allantoin, which actually has a ease of uric acid. So there is definitely hyperuricemia, which is avoided. So I think the process is clear about the behind the scene biochemical pathways. Ma'am, do you want to contribute something before we take it ahead?
No, go ahead. I think you have explained it in detail, and that is what we want our audience or our participants to know, that the mindset of only looking at purines as the purine metabolism through the intake of protein is incorrect, and we need to look into these other aspects and other pathways and find out what are we looking at, and then go for the correction of these hyperuricemia and vice versa the hyperglycemia too.
Exactly. We will definitely talk about management. We've taken a case. We will definitely talk about it. We will get Salome ma'am's inputs also there. So this slide so beautifully tells you that extracellular uric acid and intracellular uric acid. This looks at intracellular, looks at the renin-angiotensin system. Before we go here, let me take you to this slide. This is more easier to understand. If there's an hyperuricemia, now we've spoken how there can be an hyperuricemia. Now, suppose there is a now if you have hyperuricemia, look, the condition where the body is in hyperuricemia, what does hyperuricemia lead to? It leads to increased oxidative stress. It increased renin-angiotensin system activity, and definitely there is inflammatory trigger. It's an inflammation. With so much of cellular chaos behind the scene, you will have a vascular challenges, you will have a renal challenges. Vascular challenges talks about endothelial dysfunction, and you will have poor muscle glucose uptake. That's another area where hyperuricemia also may lead to hyperglycemia. You have hyperglycemia leading to hyperuricemia. We've seen the pathway of HMP. Now we talk about if you have hyperuricemia, you can, like we call it, metabolic syndrome, because the muscular glucose uptake is decreased because there's a lot of ROS produced, there's a lot of oxidants produced, there's a lot of inflammation, there's a lot of stress, there is a lot of H plus peroxides, there's a lot of oxides. So all these free radicals create a cellular chaos leading to decreased insulin sensitivity and definitely hypertension. So friends, this is so wonderful to understand that one uric acid in my blood can behind the scene give me lot of cellular challenges where my concern is inflammation, oxidative stress, and working on energy metabolism. So intracellularly, what happens with hyperuricemia is I have renal angiotensin system activated. So that is a risk at vascular system. It reduces nitric oxide formation. We know that nitric oxide is a very potent antioxidant. It's a superoxide, it's a nitric oxide which works at a vascular level. So you have a very poor vascular system here with hyperuricemia. You need to address hyperuricemia at the earliest. You also have mitochondrial dysfunction, and you also have lot of free radical generation. Energy is depleted. Maybe this patient, because of increased amount of inflammatory triggers, increased amount of oxidant generation, superoxide generation, and depletion of nitric oxide, she is having lot of ATP depletion. There's a continuous muscle pain, there's continuous back pain, there's no typical gouty pain, but she is complaining. And now we know that if there is an intracellular uric acid metabolism which leads to depletion of ATP, your energy levels, your muscle pain increases, your energy level decreases. So this is about intracellular, which actually leads to an endothelium dysfunction. And then we're talking about extreme, we are imagining a situation, if in hyperuricemia go unaddressed, what may happen. And at a renal level also, we know that classical kidney pathway, we know that uric acid, 70% excretion is to the kidney. Deposition of urate crystal, and then inflammation triggers. And that is why we have a very high pro-inflammatory response in an extracellular uric acid pathway. So friends, we are now looking at why does a patient have a hyperuricemia? Is it the overproduction or is the underproduction? We have to look holistically. We need to learn the patient management and we need to understand it can be a very simple way of looking at folic acid metabolism. It can be obesity management. So uric acid is all about at a molecular level, looking at how do I work on the basic challenge of that particular individual, very personalized way. You can have infection. Now, if you look at the slides, it so beautifully explains patient had COVID infection. So infection triggers inflammation. Infection triggers ischemia. Infection triggers immune response. Patients increase carbohydrates in the diet, not much calories, but all the calories which she has is more from carbohydrates. So increased energy, alcohol, exercise, even when you starve, increased starvation also depletes ATP. When ATP depletion takes place, mitochondrial dysfunction, that also might lead to a lot of generation of oxides, peroxides. So low oxygen, everything can be. So understand the patient's background. If you have an athlete coming to you with hyperuricemia, you know there's a lot of ATP management which needs to be addressed. So this is about the behind the scene management of uric acid. Now we'll talk about MNT. Ma'am, should I go ahead with MNT or should
Yes,
we?
please. Yes, please. Go ahead.
Should you work on? In this patient, what did you feel? I mean, by now, I think, friends, you must have understood that how will you manage? Will you cut down protein? We've not spoken about protein at all. We said dietary purine can contribute to 10, 20% or 50%, not more than that. Now, what should you work on? I mean, you all must have mentally calculated what you want to work on. If you ask me, this is my way of looking at it. I mean, it's again an individual dietetics point of view. Every dietitian has her own liberty to make an analysis, make an analysis of what she would be addressing in this patient first. We are open to discussion, debate after this. I have looked at it. Salome ma'am also have given consented to this, but I definitely she'll give her point of view once I finish talking about the MNT. I thought in this patient, carbohydrate is the major culprit. Hyperglycemia, she's been diabetic. There was an inflammatory trigger because of COVID. She's being into a menopause state where the body definitely in menopause has higher estrogen imbalance, where it might contribute to poor antioxidant support in her body. So there was inflammation, there was oxidative stress, there was hormonal imbalance, not the weight per se. She needs a lot of anti-inflammatory support and antioxidant support is what I thought should be the primary focus in this case. Weight loss is not really too much. We can discipline in her diet, controlling carbohydrates will help her. Maybe her muscle uptake of, she's not overweight. Maybe I also look at the point of her muscle uptake of glucose has been decreased because maybe hyperuricemia or maybe poor muscle mass because of her overall and inflammatory status. So just friends, we screen, we look at the goals. I have two goals, hyperuricia management and her glycemic management. I would like to look more into a holistic way where I thought this diet chart, which we just had in recall, can be modified. I just thought I'd put this diet chart again for you to understand what she was eating. Now, what can we tell her? I've not gone into details of calorie, protein, fat because it's again a very personalized way. We wanted to understand the management here. And then once we know what she's eating, and in the world out of hyperuricemia, you have so much to talk about, the vegetables, the milk, the lentils. This is a typical purine metabolic diet. I mean, when you give a diet chart to a patient, and patient also Googles it out and tells, I'm not supposed to eat this and this vegetables, palak, methi, tomatoes, mushrooms, all these have higher purines. Let's give 1 or 2 minutes for this areas and then we'll try to understand. These foods, why are these foods highlighted? These foods are highlighted because we've looked at purine. Purine is adenosine and guanine. Foods which have a higher amount of purine in each category of food groups have been highlighted. But they are not very high except for protein-rich foods. Proteins have a very high amount of purine, but otherwise your vegetables and lentils don't contribute a lot. We can always look these foods. Yes, they have purine. We are not negating it. We know that oats has purine. We know that bran has purine. But can I make a quantitative approach where I can tell the patient you can have 1 serving of grain. You can have 2 serving of lentils. You can have not over for fermented foods, but you can have normal foods, curd, fresh curds or milk, 150 to 300 ml. Few vegetables, whatever are listed in high purine, can be quantified. The tinned fruits, normal fruits, we can always say avoid them, but then we can always look at non-veg and all these stuffs, alcohol and soft drinks. So we can make this food chart where we quantify it. Every dietitian can look at it differently, but these are the foods which are highlighted to have a higher purine, because the purine, if you look at the structure of purine, adenosine and guanine, that is how the purine content, because we know the plant have their own proteins, the plant have their own way of looking at its own nutrients at a molecular level. And if you have a higher content of purine, then I think that are highlighted to tell you that don't have this because they have higher. But how much higher? Not much higher. It's very contributing to very minimal amounts. So do not minus these foods is what I feel. I think we'll take for Salome ma'am's opinion also. So my job was to look at the muscles, because I want her hyperglycemia to be taken care with good muscle health. Because that was what was lacking in her as a postmenopausal, pro-inflammatory, inactive. So I pushed little good exercises, muscle training exercises, not weight training, but strength training as per her condition, very tailor-made, and put proteins in every meal. If you look at the diet chart, it has a lot of antioxidants, anti-inflammatory. It has protein in every meal, 5 to 10 grams of protein. We are not looking at 20 to 30 grams of protein. 5 grams of protein in every meal can take her diet to almost 30-40 grams per day. So her meal is mixed glycemic load meal, where she has fiber, she has protein, and she has a small amount of carbs. So we try to balance a diet with a carb, with the protein, and with the fiber, and good amount of antioxidants, good amount of colors in her diet, and looked at her that her infection or inflammation is taken care with a balanced way of looking at macros, but focus on antioxidants, focus on anti-inflammatory, focus on muscle training and glycemic load. Maybe if with glucose control in her diet, with muscle uptake, her uric acid may settle down, and plus she is definitely on medications to manage her hyperuricemia. So friends, this is how I thought that we can start looking at uric acid from a different perspective. Because we have to start looking uric acid. What does uric acid do? It decreases my nitric oxide. It prevents my superoxide dismutase, which is a very potent antioxidant. It's a scavenger. It promotes pro-oxidant and pro-inflammatory actions. And that is why if I have an approach which talks about anti-inflammatory, antioxidant, it has a better perspective. You studied foods, which I thought I will highlight, are apple and banana post-meal. Because of good amount of flavonoids, quercetin, antioxidants, and maybe it says to have inhibit because of fiber content, and so the amount of glycemic load of this food, like banana or apple, maybe if she's diabetic, we'll give her apple because she's it's not diabetic, we can talk about banana. But this is studied, and that it may say that the antioxidant, flavonoids, quercetin, and vitamin C can help. Folic acid, definitely through food, folate, magnesium, fiber. So French bean is another food which said to have anti-uric acid property. So let's make the most of nutrition, and through the nutrient-based management is what is the holistic approach which we are looking for. So that's all from my side on this case. I would like Salome ma'am to interpret what she thinks about the case, and we'll open for questions. Ma'am, over to you.
Thank you, Geeta, for a detailed explanation and total overview of urine metabolism, the degradation, the vascular, and the role of anti-inflammatory or inflammation, role of inflammation in hyperuricemia, and how do we take care of it as overall aspect. We will definitely not deal with how generally everybody's response is that to cut down the purines from the high protein meal. So cutting down protein is only not going to help our clients, but it's going to worsen it. Maybe with a glycemia, hyperglycemia also, and to improve the endothelial function and the vascular and the function, we really need to have some amount of protein. Here we are looking at the assessment. If I'm sure all of the participants will assess this case, and you will know how many percentage of carbohydrate is coming from the diet, how much of protein is coming. We are all Indians. We have a lower protein intake, first of all. We all have a high carb intake. We sometimes have a high to medium to low fat intake if we are little conscious about it. As Geeta has rightly pointed, this is a menopausal woman, just recently menopaused, a 51-year-old who is not exercising and also complaining of muscle pain, where she spoke about how the muscle uptake. And that is where the role of exercise along with the diet comes. Generally, your client will say, in this situation of muscle pain, you are asking me to exercise. So the rightly said by Dr. Geeta is the strengthening exercise or just initiate exercise, which will also have a role in reducing the uric acid. You are also going to give foods which are going to add into excretion of uric acid through kidneys. So that is why the water intake comes into the picture, the fiber comes into the picture. She rightly spoke about adding vitamin C in the diet, increase vitamin C, or sometimes if you check your own diet of today, how much vitamin C or what was your intake of fruits and vegetables which did give you vitamin C. So sometimes it just zeroes in. We are not able to take it, or sometimes we forget, or there is no fruit or vitamin C intake. So that also, if you have taken a detailed history, she did have 2 fruits in her diet. But to improve her uric acid, to convert the pathway, we really need to add at the right time. And she did say about high purine foods, which we are not concentrating in a major way, but we are distributing throughout the day with 5 to 7 grams of protein in every meal, reducing the carbohydrate, adding the antioxidants, adding the all colored vegetables, adding the fiber and the water, and thus managing not only hyperuricemia but hyperglycemia with say prescription of say 20 to 30 minutes of exercise, which could be just a normal walk with strengthening exercise, which is going to help her to come out of this situation, that is her muscle pain. So if we look at as a nutritionist point of view, independently we are treating nutrition diagnosis. So if you have to write down nutrition diagnosis in this case, I'm going to leave it to all to you. What will be the diagnosis based on your parameters, based on your both anthropometry and biochemical parameter and your diet history? What will you come to, and plus the symptoms? And the PES system, if you write, you will individually, as personalized nutrition, we will be managing this patient. And I think within 4 to 6 weeks, this client will be totally relieved from her symptoms. We are not looking at weight reduction here because we don't need much of weight reduction, but by altering her food habits and the diet, the way we saw in the prescribed diet, is automatically going to reduce the weight, and she's not very obese. So that is where we need to concentrate right from the morning till night. How are we adding enough of antioxidants and anti-inflammatory foods in almost say 3 to 4 meals in the diet, and convincing the patient that this is going to help her improve her clinical status. So if she has rightly put exercise, hydration, the nuts. I've seen many people avoiding or restricting nuts in the uric acid diet, low uric acid, which is of course not necessary. Nuts are, we know, good fat, and which also give a good amount of protein when it is included along with the meal. Then inclusion of fiber in the form of fruits and vegetables, fibrous fruits and vegetables is very, very important in at least meals, that is your breakfast, lunch and dinner. And then most people also omit milk and milk product. There is no need. You can give an allowance. Yes, lactose and gluten we were looking at, but you can allow 300 ml of fresh curd, which is freshly made, like morning made and afternoon consumption, afternoon made and evening consumption. I think it's going to do more good than the adverse for in a diet of a person with hyperglycemia and hyperuricemia. So we looked at overall how do we combine foods, how do we have the calorie to energy ratio, how do we utilize the nutrients which are consumed by us or by a person, and how do we reduce excretion of the increase excretion of uric acid and reduce increase utilization of uric acid by different pathways. So rightly explained. So always look into what your client is consuming, what is your assessment, and the background metabolism, how the uric acid, the mechanism by which your uric acid has increased. So if you keep it in mind, I think you will best manage your case with this. And you can also give vitamin C as supplements or vitamin C as added food. And as she rightly explained the role of folate, we are, or most of the patients are in habit of consuming folic acid tablets, which is say 5 microgram or 5 milligram tablets they consume because they want their hemoglobin status will increase, they will feel energetic. But we saw the what does the folic acid do. So what we need to do is concentrate on folate and other vitamins and antioxidants which are going to help us to have a better health, overall good health, and control both hyperglycemia and hyperuricemia. So we take questions from you. If anything more, Geeta, you want to add, Nasneen or anyone wants to add into it, because this is how right way to look at the treatment of hyperglycemia and hyperuricemia. So please, it's my humble request to all the participants to learn the right way and practice the right way to do it. We are going to give you a case assignment this time, which we want you all to solve it and come back to us in your next series of the class, BNA class, and where we will see how you have done it and where you have gone wrong and where you have excelled. And that is how it's a learning exercise. So I think, Geeta, we can put up the case.
Yeah.
Or you want to add anything, you can add.
No, ma'am, I think you've said it all. And
yeah. So this case study, yeah, go ahead.
No, ma'am, please.
For next session, we want you all to work on this case study. And this is a young male 30-year-old patient with a 32 kg meter square BMI, complaints of gout, dyslipidemia, a little diversion, but dyslipidemia and uricemia, we were talking about metabolic syndrome, if you know. So this guy is with dyslipidemia, poor energy, obesity, and maybe poor lifestyle. Sedentary lifestyle, an RT professional, having a mixed diet, maybe having an alcohol, yes, alcohol 3 times a week, and poor sleep habits. So his biochemical parameters are given here. Uric acid 9 milligram, B12 is 100 nanogram, dyslipidemia, which is a TG 300 milligram. If you remember, we have dealt with TG, the high TG also in the explanation of the pathway. So how do we look at this and how do we reduce triglyceridemia and uric acid simultaneously? and also with cholesterol 200 milligram. So when you tackle these parameters, TT, uric acid, and dyslipidemia, I think this particular young male will definitely be treated how we want to explain to him, or at this age, if he has this parameter, what are the consequences in the later stage, and how well we can counsel this person to comply and adhere to the regime we give. That is up to each one of you in the individual counseling, based on the physiology, based on the mitochondrial knowledge you have learned today in this session.